Welcome to Imperfect Heart, a place for you to join me, Jeff Holden, in conversations, discussions, and dialogue about our hearts and the impact myocardial bridges have on them. We'll talk with healthcare professionals, those in related fields that support our condition, and others just like us with stories of their myocardial bridge experiences. It's my intention for this content to inform, educate, entertain, and even motivate or inspire you in your personal journey on dealing with a myocardial bridge. Most importantly is to have you leave each episode with hope, knowing you're not alone and that what you're experiencing is real. So imagine you are going to see a new doctor, in this case, a new cardiologist you've never met before. He doesn't know you, you don't know him other than what you've been able to do a little research and homework online to vet him a little more properly. Well, that's the case of the story I'm going to share today, and it's the episode you're going to listen to in just a minute. But I thought it needed to be set up properly so that you understand the situation. I had my surgery on January 4th of 2022 at Stanford, and all my follow-up procedures were at Stanford. And so for the next year, that was all Stanford docs, Stanford cardiologist, Stanford thoracic surgeon, Stanford testing for anything else that needed to be done. Now, another year goes by and I think, oh boy, I have not been to a cardiologist in an entire year since I left Stanford. I probably should reach out and get somebody. So I ask a few people and identify a few opportunities. So I'm assigned a particular cardiologist at a particular cardiology group for the medical system that I'm in. Well, I figured what I would do is I would go in with a microphone. Since I'm new to him, he's new to me, we're going to see if we've made any progress with regard to the understanding of myocardial bridges. Now, can you imagine some new patient you've never met before, have no idea who he really is, walks in with this recording device and says, "Can I record everything that we're doing?" And I give him a little bit of an explanation on what we do. I record podcasts. I have a healthcare podcast on hearts, and I don't get too much into it because I wasn't sure where he was and I didn't want to taint any of the conversation. He actually says yes, which I was very, very pleased with. I come to find out that my Stanford medical records had not been transferred to the healthcare system that I'm in locally. So they didn't know anything about the myocardial bridge treatment, the unroofing procedure, or anything that had been done other than what I left them with last, which was something's wrong. I'm going into ventricular tachycardia as a result of vasospasms, and I was wearing a life vest in November of 2021. And I don't offer all that up immediately, which you'll hear in the conversation as we're recording everything, because I really wanted to vet how he was in terms of his understanding of myocardial bridges. Well, we all wish this was the first cardiologist we saw, because I was blown away by the fact that he not only was aware, he acknowledged it. He said, "Oh yeah, they're definitely symptomatic. We understand. We talk about this in many situations that we see come through the cardiology group. It's up on our wall to always be thinking, could this be a bridge?" And you'll hear the conversation that Dr. Lingam and I have as we orient ourselves to each other as my new cardiologist. And I want to, in advance, thank Dr. Lingam for his willingness to do this, because that's a pretty confident move to let some patient you don't know walk in with a microphone and record the first conversation of your journey. So Dr. Lingam, again, thank you for your awareness of what our situation is. And for those of you who are new on this journey, this is what you're looking for at the very least, that your cardiologist understands the bridges, and then if you were presenting in a different situation, that he would work or she would work toward the goal of getting something taken care of, because they do know that these are a symptomatic condition. So without wasting any more time, my first meeting with my new cardiologist, Dr. Lingam.
I don't know what you know about me.
About 2 years ago, you saw Manon.
Yes. And I scared him into teaching.
Yeah, he couldn't do both. He couldn't multitask.
No.
So, yeah, it was literally in November 2020.
Correct.
Had a few runs of ventricular tachycardia. They transferred you, or did they transfer you to Stanford?
Yes. Yes.
Radiation and resuscitation.
Correct.
What was the outcome of their transfer?
Did they? Myocardial bridge.
Oh, the LAD bridging.
Indeed, yep.
What did they do? They
They unroofed it, yes.
right.
So that's part of the question. So you recognize the condition, which is great. What's your understanding of it?
It's a genetic thing.
Yes.
I don't remember on top of my head the incidence of myocardial bridging. I had another case and I was going over that angiogram with him. She was this client, now she's a medical student. I was going over how that is done. And even though it's a simple thing, you still have to do surgery. Like you literally lift it off. Yes, yeah, that's what they do. It's a simple surgery. But at least not everyone needs it. You had VT, so you more than needed it.
Well, the vasospasms, too, they were caused by the endothelial dysfunction, which was a symptom of the heart compressing the artery for so many years.
How did you do since then?
Fine.
Perfect.
Literally asymptomatic. And that's an unusual situation. Not everybody comes out of it. So fortunate. But I had a 5-centimeter bridge. There was a long.
That's a really long bridge. I should go back and look at that cat image.
Yeah.
Because usually we have barely 1 centimeter where you could see that small area, and we kind of use nitrates or something and not really put you through surgery.
Right.
Probably VT was what called for surgery. Did they do minimally invasive from breaking it in?
No, they couldn't. They had to go in.
They had to cut it.
And I also had pectus excavatum that was compressing the heart. So they said, we're going to go in and fix that because we're not going to do all that work.
Got it.
And then,
So they had to.
right. So I had a thoracic surgeon come in after the heart surgeon.
Let's fix it this then.
Fix the VE.
And you went to the best place. So, it's down the West Coast. Yes.
They have a department that's been doing research on bridges. And what we find is that so many people have them and so many people get misdiagnosed.
Right.
Because
myocardial bridging is not picked up that quickly.
right.
Because you're concentrating on how is the movement, you're injecting the dye, everything is good. All right, it's got to 13. You just have to have the dye. But lately,
The detection is pretty high. I mean, well, please tell me that because
Yes.
part of our emphasis is to raise the awareness in the cardiology community.
no, even in our boards, when we have the boards, we do have one myocardial bridging so that people don't forget that.
Yeah. Oh, I'm
So
thrilled to
it's
hear
that, and then that's part of the training. I don't think an interventional cardiologist would ever miss a myocardial bridge. Because what happens is when, let's say I'm doing a angiogram for ventricular tachycardia, I'm already looking for a good reason for VT. VT doesn't happen just like that,
Right.
okay? 8 out of 10 times it is due to blocked arteries. The other reasons could be infections, could be there on a few other conditions. But in general, 8 out of 10 times it's to plugged arteries. So you're looking for it, and then, wait a minute, this is the reason.
Because you don't see the blockage.
You don't see the blockage that is obvious,
Right.
but then you're having an electrical disturbance that is due to that.
Yeah.
So that's when that gets picked up.
Quickly. Yeah. And we found
So
the CT is the quickest way to catch it when you see
Right.
something.
the reason we don't do CT is we know, let's say you have a blocked artery. We need to fix it right away
Right.
to prevent VT. If I do a CT, and then if I do an angiogram, you're getting 2 diodes and you're getting radiation twice. Why bother putting you through that? I mean, if you're a non-diabetic, you can handle 2 contrasts, double the contrast load and double the radiation without a trouble. But if you're a diabetic, then you don't want to screw up your kidneys.
Yeah. That's helpful to know. That's the first time we've heard anybody say that.
No, that's the reason why we don't jump on it. Sometimes in the emergency room, you have chest pain and it's not sounding like cardiac. We end up doing a angiogram to rule out lung spots.
Mm-hmm. Yeah.
And then it comes back as no lung clots and you're having chest pain, then we're still stuck with, say, doing an angiogram.
Right.
Which means you're still getting twice the radiation, twice the contrast. But there we don't have a choice.
Yeah.
I mean, because of the story, depending on who is first evaluating you in the emergency room and what their comfort level of moving this way or that way.
Right. Okay.
I mean, do I call cardiology right away, or should I do this, and then call, all these things, say,
Yeah, that's interesting. I didn't know that.
Yeah, no, that's
Which
the reason.
makes sense then.
Right.
Why you don't go into that process first.
Why we don't do a CT.
Yeah, make sure you got it.
There are always there are all these conditions where we call this triple rule out. Triple rule out means when somebody goes from the chest pain to the emergency room. Is it because the main tube that comes out of the heart, the aorta,
Yeah.
is that leaking or ruptured or dissected? That's a big thing. That's a emergent surgery. Or is it because of a lung clot, pulmonary embolism? Or is it because of a plugged artery?
Yeah.
That CT scan can do, but the IV contrast has to go through different phases. So the triple rule out is not that simple. The radiologists have to work on when the contrast is going. It should go into the arterial phase. It should go into the venous phase. All these things have to be looked at before you can totally call. There's no clot. There's no dissection.
Right.
There's no heart clot.
You don't want to stroke a person or
Right. And then we don't want to, and then you're literally frying the patient. Yeah.
Right.
If I have 100 patients coming to the ER with chest pain, if I put all of them through this,
Yeah.
that's going to be a huge healthcare expense.
Yeah. Okay. That makes sense. That makes sense.
Across the world, imagine that. It's like,
Oh. Well, one in four of us has this condition, so it's like,
yeah, but 5 centimeters is really large. I mean,
yeah.
I have to, obviously that's why you have the unroofing.
Yeah.
I have seen 2 centimeters too. 5 I have never seen.
Yeah.
But cath is not my thing.
Yeah.
So
And we see people, so many of them, it just buries.
right, it just varies. It's the toss of the point. There's no right answer.
I wish we knew what caused it and save so many people the trouble.
When we don't have a good answer, we throw it on the genes.
Yes.
We blame it on the genes.
So
Because,
yes, I'm thrilled. This, by the way, is a good doctor because so many doctors don't recognize that they call it benign. And
if it, in your case, it's obviously not. It's VT is like the final straw. You cannot ignore VT.
right.
Because VT kills people. When somebody has heart attack,
Yeah.
VT is what kills them.
And I did on the 26th of August, 3 years ago, I had a heart attack. I ended up with a myocardial infarction. And
And is that your coordinator said if I go home or what?
yeah,
Yeah.
everything looks fine.
Oh, and then we detected this afterwards?
This, because they couldn't understand why I was still having the pain. And I kept coming back. I said, look, and this is
Okay.
This is wrong.
I missed that part.
Yeah, so this pain will not go away, and it's severe. And so they ended up, I had enough.
Taking you back to the cath lab?
Yeah, and I had cardiac MRI, and then they did everything, and then they said, well, you have this bridge, but
It's not bad enough or something?
yeah, they didn't really get into the bridge. They saw it as benign at the time. It wasn't so much Rishi was the electrophysiologist downtown. And
Yes, it's the Krishnan or something.
Yes.
You saw him in November.
And so he said, we could do some testing, but we don't do that type of testing. We suspect vasospasm. The vasospasms were triggering the VT. So I'd have these really severe episodes of vasospasm, which would create the pain,
Wow.
but you wouldn't see it because you can't see a vasospasm unless you're in there.
We have medical residents in training now. If you were here, I would have made them make a case report on this one. This.
I'm happy to talk to anybody at this point.
Now, and next year we are getting cardiology fellows. We could save this case as
Please.
a discussion point, if you don't mind.
Absolutely, yes. Okay. Yeah, so the vasospasms were triggered VT runs. They would be on the light vest because they weren't sure.
Did that go off at any point?
Twice. Wow. But I didn't pass out. So I was awake, so I was able to shut it off. And
Good. We got a good case today.
and I don't want a defibrillator. I said, let's figure out what the problem is. And then that's when they said, you need to get a provocative test to identify what's causing the vasospasms. And then, of course, I was fortunate enough to get into Stanford.
We used to send, I was at that Hitchcock for kind of QG, and he used to say, okay, go to MGH. So, and I trained in New York and then I saw that action. So, we used to have all these big places saying, okay, I'm going to go there. It's like, okay, it's not too far away. Go ahead. Give it a shot or something,
We actually had a doctor from Yale who is now doing a clinical trial on Inoka. He's trying to identify
Inoka?
Inoka.
I was just talking about it.
So why do people present with condition when they have clear arteries? And of course, myocardial bridges, one and
or sometimes you could have diffuse disease.
there are others,
Years roll by with high LDL and, it's a, Inoka is a very, I think it's more prevalent than what we give credit to.
I think it's one of the studies happening as well. So it's accumulating 500 patients over 5 years.
Okay, where is the Mayo? Where is Mayo?
Yale.
Yale is doing it.
Yale's doing it. Mayo's inclusive. Mayo's participating. Cleveland Clinic's participating. Stanford's participating.
Usually that's all the big brothers.
Right.
They have the bandwidth to do all these things because they have more people to work with, and also the bandwidth they have with enhancers and everything.
Yeah. We have him in there as one of the episodes.
Who is that?
His name is Dr. Samit Shah. About your age, young guy.
Samir Shah?
Samit Shah.
Oh, Samir Shah.
Yeah.
So what do you do? What do you do for a living?
I produce podcasts. Coincidentally, I produce.
When I go for walks, I used to listen, but nowadays, it is something called VUMEDI in medicine. VUMEDI. I don't know if you know that familiar. It's VUMEDI. That's which has all the medical talks. So you could custom that into cardiology or pro into cardiology or something. And all the latest talks, you have, and even if it's a big guys, whoever, in the academic circles, they talks come on it.
Yeah.
So all my podcasts are gone, and now I just listen to those.
Like as a patient, I'm happy about that because you're learning more about the condition.
Right. That's the only way for me to catch up on the new instruments. So.
Yeah. Well, and this is doctors and patients, so we alternate. Yeah. Typically, we've had the top 3 robotic surgeons for cardiac repair of the myocardial bridges, as well as the doctors who did me. Dr. Boyd at Stanford, who's the #1 surgeon in the world for condition because he's been doing it for 12 years.
Okay.
So he's probably pushing 300 cases now of myocardial bridges.
Yeah, because, the thing with the higher centers or centers of excellence is all these end up going there. So the regular surgeons kind of say, okay, you know what? Surgery by itself is not that hard.
Correct.
Except, the volume is lacking.
Yeah.
So Mayo Clinic and Stanford, all these guys end up getting all the, and thankfully, if your insurance improves and, all those other things also are there.
Well, I compliment you guys and the whole Sutter system because once you realized the defibrillator wasn't an answer for me, I'm very active. I'm a cyclist. Doesn't fix me. It just protects me. And everybody was willing to say, well, then let's take that next level for the test. And then the test was conclusive. It's okay. Yeah,
When I run into him and I let him know that you're back here. And
I do. Well,
you don't mind that, right?
Oh, please. He's the second episode.
Yeah.
Richard came out and we talked about the whole case.
Oh, he did. Okay. He still does some podcasts, I know.
Yes.
And wellness, and he's made the wellness director or something for something, GMD
for him.
For all the residents and everyone.
Yeah. And I spoke with the ladies up at cardiac rehab. You could like to do an episode on that just to identify what it's like when you do get repaired.
Yeah.
What that process is. Just to have people get anxious, that first time out. But what's happened is it's been 2 years now since I was a year on Stanford's follow-up. Mm-hmm. And I figured I don't have a cardiologist.
Yeah.
I have a heart condition.
You probably don't need one anymore because it's fixed.
I have very little might, yes. I want to keep it right.
You need to at least get an echo, make sure everything is okay. Do you need nitrates or not, depending on how you do? If you're biking and not having chest pain,
I'm fine.
And not really on any aspirin?
Just baby aspirin. They said stay on that. And they had an Lipitor.
How much is your LDL? 51?
Pretty just, Yeah, I've been on that since I left, but I cut it to 20. They said 40. I said,
As long as your LDL is below 70, I'm okay.
Yeah.
There is a push for lowering the LDL below 55.
okay.
For
Patients
patients,
that are,
for patients who already had a stroke or a heart attack
got it. Okay.
or required stents or bypass.
Okay, good.
But a part of me is like, why do you have to wait until these things happen? Why not for everyone?
Yeah.
So it depends. If I'll take it, if I can push it.
Yeah. Like I said, they had me at 40. And I said, I'm going to cut it to 20. It's too, I don't know why I need, that's the maximum dose.
I mean, it has other benefits too, but in your case, that is a congenital condition that's fixed and otherwise your arteries are okay. So
The one thing they did say, because they had to do the bypass, because where the artery enters the heart, there's always some sort of blockage.
yeah.
And I had some soft plaque there.
Oh, okay. So you did have some.
Yes. Yeah. At the point of entry only, everything else is fine, which is not unusual. And they said, what I'd like to do is protect that. And I guess the Lipitor does protect in some way
Okay.
the soft plaque from possibly rupturing.
Right. So it softens the plaque.
Oh, it softens it.
So if you have a hardened plaque that's prone for rupture
Okay.
because you have a calcification
Yes.
that is hard and the bloodstream could rupture what? If the plaque is soft, it cannot cut loose.
Oh.
It cannot come loose.
So they want to keep it soft.
It's to keep right or soften it more.
Okay.
There are multiple other advantages of improving the endothelial function of the lining,
Okay.
that the statins can offer, apart from lowering the LDL.
Okay.
Okay, so that's an additional advantage of the statins.
And I'm going to clarify that just for the benefit of
Yes,
who are listening, that the statins can actually improve the endothelial
total
function.
not can, will,
Does.
does. Okay.
That's a
So,
big deal.
and that is a big deal. So that's why even if your LDL is normal or below 55, anyone who had a vascular event meaning mini stroke or TIA, or a stroke or heart attacks requiring stents or bypass,
Yes.
or heart attacks not requiring any of these, but you have plaques, which means, yes, you had a heart attack from minor branches where we did not have to revascularize, but you have a little bit of plaques that are seen on the images. That is reason enough to justify statins,
Okay, good.
regardless of your LDL level.
Okay. Well, I feel better about that too.
People get a lot of bad rap on statins, but they don't understand what they did over the last 40 years. The incidence of major vascular events have drastically come down due to statins. And nothing else.
Even with the people who are experienced, not everybody has endothelial dysfunction as a result of the bridge, but for those who do.
So endothelium is a lining of the internal side of the arteries.
Right.
Any rupture of that endothelium at any point to the entire vascular tree can cause endothelial dysfunction. So it starts from the aorta. The minute the aorta comes out, to the arms, circles around, goes to the belly, to the legs. Wherever you have a rupture, wherever plaque rupture happens, that means the endothelial lining is disrupted. Once the endothelial lining is disrupted, the nitric oxide that comes from the endothelium could be coming down. It's not
proportion.
out of proportion
Yeah.
where it should be. And that's why you need to take care of the endothelium.
Spasm.
And more the nitric oxide that is emanated from the endothelium, the smoother the vascular muscle is, and constriction chances are less. The spasm chances are less.
With the statin to protect.
With the nitric oxide.
Oh, with nitric oxide. Okay.
Right. And this helps.
Yeah.
Statins help. They'll keep the endothelial function.
Got it. Okay.
Then all right. So for the Lipitor. So you're not going to get off of the Lipitor if you already said you had a plaque. I have to go back to the Stanford records and pull up your op report and paste it into my note because you did not see menin after the report. So I could go back there somewhere and pull it out. I wish I can help.
Yeah. Anything I can do to help.
So we could keep you for follow-up once a year.
Sure.
And take it from there. Maybe at some point next year I could and have a reason to update your echocardiogram? You had one before you went there? Is that?
I'd had several.
Okay. After you were there, you had...
And I did it again. I did everything again at Stanford.
Okay, then we'll pull that up from there and then take it from there. I don't... You had a monitor also in October of 22.
Mhm.
So you did not have echocardiogram since discharge.
Correct. Yeah, the monitor was just altered.
To make sure you did not have a VT.
Well, it was after the surgery. What they wanted to do is just watch I have an arrhythmia just from cycling long distances over time. They said it's not.
Arrhythmia is a big word. What arrhythmia did you have?
That's a good question. My heartbeat is not 100% regular.
Okay. But is it sinus arrhythmia or is it AFib?
No, it's not AFib.
As long as it's not AFib, we are fine.
Yeah, no, it's not AFib.
I'm looking at the Holter monitor from October 2022 and 3 episodes of SVT and no AFib, no flutter.
Yeah.
Overall.
And those are pre.
That was October 2022.
And surgery.
Was in November 2020.
January 4th.
Oh, January?
Yeah,
Okay.
January 4th. And you might even want to go, if you go to November, you'll see all the testing. That's where the provocative testing will show up. November of 21.
Again, thank you to Dr. Lingam for his candid discussion with me, for his awareness of myocardial bridges and the fact that they are symptomatic, and for the fact that we can share this with any other cardiologist that you may be establishing a new relationship with. I would suggest, if anybody has any questions, to reach out to Dr. Lingam, and I will have his information in the show notes for this particular episode. Again, thank you. I hope you enjoyed it. I hope you get something out of it, and I hope it helps you on your journey as you try to identify proper diagnosis for the condition. Thank you for listening to Imperfect Heart. It's my hope that this information helped in some way to improve your situation or will help you better understand this condition. More importantly, that it gives you hope through stories that there is help and you most certainly are not alone. If you've been diagnosed with a myocardial bridge, please be sure to join the private Facebook group, Myocardial Bridge Support Group. For more information about our program or to reach me directly, visit the website, myimperfectheart.com. If you like what you heard today, please give a positive review, thumbs up, high five, or whatever your app likes. And be sure to share with everyone important to you so they understand what it is you're dealing with. Please subscribe as well. Welcome each day with gratitude and positivity. The views and opinions expressed in this program are solely those of the host and the guest and are not intended to provide, nor are they a suitable substitute for, professional care by a doctor, therapist, mental health professional, or other qualified medical professional. Imperfect Heart is a production of Hear Me Now Studio.